Let's move to some ovarian cancer discussion. Last year, we had met around the same time here at ASCO, and we chatted about the value of CA-125, so I figured we're sitting back and let's now talk about news as it relates to ovarian cancer.
So in the opening webcast for the American Society of Clinical Oncology, we highlighted an abstract that looked at age-adjusted serial CA-125s in women, in 3,000 women. And when their levels increased, whether it was an intermediate increase or a large increase, it then triggered repeat testing. And through an algorithm of risk, when the CA-125 increased to where they were categorized as elevated risk, we then did transvaginal ultrasounds. So we weren't screening on one number. The screening by an algorithm defined by researchers, screened based on a graphical trend that then triggered transvaginal ultrasounds, and those results then triggered a look from a surgical oncologist. And in the study, 8 women were taken for eventual viewing by a surgical oncologist, and 3 of the 8 were diagnosed with early stage ovarian cancer, and the other 3 were diagnosed with borderline tumors. And we screened 3,000 women to find 3. And I think whenever we talk about screening, we need to think about time, cost effectiveness, in terms of whether this kind of change on the old would be effective. And what the researchers are doing in the future are mounting a much larger trial in 20,000 women. I wish we had a new proteomic or a new molecule, but it's kind of a new way to make CA-125 work for us.
And the HE4 is used in combination with CA-125 for women who have already been diagnosed with ovarian cancer?
In certain institutions, yes.
All right, but there's bigger news as far as treatment for ovarian cancer.
There is some very interesting work coming out of this year's meeting. A randomized study conducted by the GOG, the Gynecologic Oncology Group, looked at whether the anti-angiogenic bevacizumab can improve progression-free survival. Now, when we talk about a clinical trial, you have to understand what a researcher was looking at. And the main endpoint of interest was what we call progression-free survival, meaning time of life without the disease worsening. That's very different than overall survival,
right,
meaning that you live longer.
Right.
So what researchers did is they took women with stage 3 and stage 4 ovarian cancer and randomized them to one of 3 treatment arms. One treatment arm was our standard therapy, carboplatin and paclitaxel for 6 cycles, followed by placebo, a sugar pill, maintenance. And maintenance is longer term therapy for a defined amount of time, and this study was 10 months. The second arm was chemotherapy and bevacizumab, followed by placebo maintenance. And the third arm was concurrent chemotherapy bevacizumab, followed by bevacizumab maintenance. And researchers found that women with this disease were alive 4 months longer without progression when they received concurrent chemotherapy with bevacizumab, followed by bevacizumab maintenance.
And we're talking about Avastin for viewers who may not recognize the name. Right.
Avastin. And I think what's interesting about this is we have to say, is that a worthwhile thing for patients, progression-free survival? For some patients newly diagnosed with ovarian cancer, they have minimal symptoms. And if we can prolong that time before their disease worsens, they can feel better and live better. And that's the argument. There has been also much discussion in the ovarian cancer world that progression-free survival is a surrogate for overall survival. But this study may never have overall survival as the endpoint, because once women progress on their therapy, they're free to go on any chemotherapy. And that can then affect how long they live. And some of the women, since Avastin is commercially available, could then receive Avastin. So I think what we all look for is overall survival benefit. But in advanced solid tumors, sometimes this kind of endpoint is what we have.
Well, this is a very significant shift and move forward in the treatment of ovarian cancer.
You know, ovarian cancer researchers, the GOG, and researchers in Europe have always looked at how do we improve platinum and taxane. We've looked at 3 cytotoxic combinations with no improvement in progression-free survival. We've looked at IP, intraperitoneal chemotherapy, and that's been taken up with mixed enthusiasm because of some of the complications. The complication rate with this biologic was not great. It was actually more from this normal complications that we see, and really no greater from the control arm. So I think, yes, in a way, this may be a very interesting therapy, but I think it's going to come down to a patient talking with their physician about the drug and the time commitment, and what do they want at this point in their life.
So in a broader summary of everything, ASCO still goes on for another day or so. From this meeting, 2010, what are you leaving with as you go back to your institution?
You know, actually, every time I come to ASCO, I think I'm overwhelmed by the strides we make and how much cancer research pays off in terms of improvement in diseases that were orphaned. We saw, you'll be hearing about a melanoma vaccine in a disease that had no therapy. You'll find that there's subsets in lung cancer that we can treat dramatically. We make incremental benefits in ovarian cancer. I can't say it's one thing, but I'm really moved by how our investment in research pays off.
And as a survivor and advocate, what I keep being really amazed about is when I was first treated 28 years ago, it was such a different world. You know, it was cytotoxic therapy, my chemotherapy, no supportive care, and today what I'm looking at is the world of molecular-based therapies, targeted therapy, the biology of cancer, and the landscape is dramatically different.
But I think what you say about the landscape and the continuum of care, we never really talk about. I mean, here at ASCO, we're learning about survivorship, we're learning about prevention, we're learning about research across many of the aspects of being a cancer patient. We always talk about the molecular aspects, but we don't talk about that there's a huge survivorship track and a very large epidemiology tract, so that I think all of the aspects of being a patient get addressed at this meeting with advances.
Thank you so very much for taking time out with really a lot of positive news.
I think so.
Dr. Jennifer Obel, thank you so much.
Thank you.